Liquid biopsy started well over 20 years ago. Back then, it was intended as a technology to capture circulating tumor cells. As everyone knows, cancer starts in the primary organ where it develops, and then in due time, it will metastasize to different organs. And the way it does that is that a small fraction of tumor cells will separate and escape into the bloodstream, where it will establish itself as a metastatic site. Attempting to capture these tumor cells while in circulation give us a window into the makeup of the tumor and the percentage of these cells in the circulation without having to use invasive biopsy. The technology of studying circulating tumor cells gained some foothold in breast cancer and prostate cancer. However, these were still fairly limited, and probably the practice of liquid biopsy might have faded away had it not been for the development and introduction of next-gen sequencing. This is the technology that allows us to do fairly exhaustive molecular profiling of the tumor. Initially, next-gen sequencing allowed us to examine 4 parameters of genomic alterations within the tumor. These are the point mutations, short insertions and deletions, gene amplifications and deletions, and finally, chromosomal rearrangement that give rise to oncogenic fusions. And these 4 parameters form the basis or the foundation for what we know today as precision oncology, where you're able to profile the tumor, find the oncogenic drivers, and use that information to target that driver using a small molecule, usually a tyrosine kinase inhibitor or PARP inhibitor, or many other categories of small molecule inhibitors that can modify the biology of the tumor. As the technology of next-gen sequencing became more and more mature, the sensitivity of that assay allowed us to examine the same 4 parameters I just mentioned, but rather than obtaining a biopsy from the tumor, you can actually do the same thing by examining the snippet of DNA in the plasma that has escaped from the tumor or from the metastatic site. Doing that is that the DNA in the plasma actually derived from the tumor, the circulating tumor DNA, actually has a fairly short half-life. It's usually cited as less than 2 hours. This will allow you to get a real-time assessment of the genomic environment within the tumor. So rather than having to obtain a new biopsy every 3 months or every 6 months to assess what is happening in the tumor, the short half-life of the circulating tumor DNA allow you to get a real-time assessment of what is going on in the tumor. It also has other advantages, such as it's a minimally invasive. I mean, you're just obtaining 2 tubes of blood as opposed to going through a CT-guided needle biopsy that can be harmful. It could be expensive. It also allows you to get a sample of practically every part of the tumor, the primary tumor and the metastatic tumor. So you sort of get this homogeneous picture that bypass the hardship that we have with the intratumoral heterogeneity of having to biopsy multiple sites, which might not be practical. As a result of the evolution of our understanding of the tumor biology, as well as the richness of the available tyrosine kinase inhibitors and the small molecule inhibitors, the different tools of precision oncology, nowadays almost every solid tumor has its own panel of known drivers and tyrosine kinase inhibitors or small molecules that can target these driver mutations. So what started as a sort of a subset, a small subset of non-small cell lung cancer, is now a practice that touches about almost every solid tumors, from lung to breast to colorectal cancer, prostate cancer, and many others. So the practice of liquid biopsy has truly transformed the care of patients with advanced cancer, with solid tumors, and precision oncology now is an integral part of our day-to-day management of cancer patients, thanks to the adoption of liquid biopsy. Using liquid biopsy, as convenient and as useful as it is not entirely without its own pitfalls and difficulties. The first confounding factor is that you could actually do a liquid biopsy and find nothing. You just cannot find enough ctDNA to make sense of the stage 4 cancer that you are seeing. And this is because tumors vary tremendously in the amount of DNA that they are able to shed. So some tumors are high shedders while others are low shedders. So you could find plenty of the cell-free DNA is derived from the actual tumor versus you could find practically nothing. And the best example I can give you for that is that tumors that metastasize to the liver or start in the liver tend to shed a lot of ctDNA, circulating tumor DNA into the plasma that can be captured. So a lung cancer or a breast cancer or colorectal cancer that metastasizes to the liver, you're almost guaranteed to find tumor-derived ctDNA in the plasma. On the other hand, tumors like possibly prostate cancer that metastasize, that only have metastasis in the bone or a brain or a CNS tumor, these tumors tend to shed less DNA and might pose some difficulty collecting enough ctDNA to make sense out of it. And this is, I think, a good example of that would be to simply look at lung cancer, where different subsets have different rates of shedding that can decide the success rate of ctDNA and of liquid biopsy analysis. Further, we know that squamous cell cancer tend to have high rate of apoptosis, so they shed more ctDNA into the plasma, while adenocarcinoma, which tend to be a bit better behaved and less apoptosis, so they have less ctDNA in the plasma. So that could be a factor when assessing a patient with lung cancer, whether the underlying histology that can dictate the quantity of ctDNA in the plasma. The other sources of genomic mutations that you will find in the plasma. So when you collect the plasma and find a specific mutation, people tend to assume that this mutation is derived from the tumor. However, there is actually 3 sources of abnormal genomic mutation that you can find in the plasma. So assuming that everybody is born with a completely normal DNA, there is potentially 3 sources of genomic alteration that you can find on a liquid biopsy. The most obvious thing is what is coming from the tumor. I mean, the patient has a stage 4 cancer, so that mutation is coming from the cancer. That's a very obvious answer. But there's 2 other confounding factors that you need to keep in mind. The first thing is the so-called clonal hematopoiesis. These are the pre-malignant clones in the bone marrow that obtain a set of that has a set of mutations not very different from what you see in a primary tumor, and it could be a confounding factor. Usually, it's easy to differentiate that clonal hematopoiesis from the tumor because in a stage 4 cancer, there is plenty of ctDNA and there is certain characteristics of a tumor coming from the breast or the lung or colorectal cancer that allow you to say that this mutation looks like it's coming from a lung cancer as opposed to from a bone marrow. But if you are using liquid biopsy in an early stage disease like a stage 1 or 2 or even small stage 3, the clonal hematopoiesis contribution can be highly confounding. There are 3 novel applications for liquid biopsy that has emerged in the last few years, and it's very, very possible that these will be integrated into standard clinical practice in the coming few years. The first thing that actually gained a lot of attention recently is the use of ctDNA and liquid biopsy to assess something called what is known as minimal residual disease, or molecular, more recently is called molecular residual disease. So, as we all know, patients diagnosed with early stage cancer, let's define that as a stage 1 and 2 and some of the stage 3 cancers, they are often treated with a combination of definitive surgery or surgery followed by radiation or even chemoradiation. And the goal is to eliminate the entire cancer cell population so the patient is rendered cancer-free. However, we know very well that surgery and radiation is not sufficient. As a result, the patient received adjuvant treatment that could be anywhere from a few 4 to 6 cycles of chemotherapy to maybe years of adjuvant treatment of hormonal therapy in breast cancer. But the goal is to eliminate the micrometastatic disease that you cannot see on a CAT scan or an MRI, but you know very well if you don't do anything about it, the cancer will come back. So ctDNA is currently being developed to assess for either traces of cancer cells that are still present after completion of surgery or early recurrence of cancer while the patient is receiving adjuvant treatment. The technology varies a lot from one histology to the other, so there is different applications in lung cancer versus breast cancer versus colorectal cancer, and there's a lot of debate whether you should give adjuvant treatment to everyone. I mean, the old concept of adjuvant treatment is that every cancer patient who underwent definitive surgery will get adjuvant treatment, and only a minority of these patients will benefit from it. Using ctDNA and molecular residual disease technology might allow you to reserve the use of adjuvant treatment to only those who have residual disease and spare the others from having to go through months or years of adjuvant treatment. It also, at the same time, if you do that, if you apply that test serially, let's say every 3 months or every 6 months, it allows you to detect the early recurrence. So rather than waiting until the patient has jaundice or a broken bone or something catastrophic event that tell you that the cancer has come back, you could actually anticipate the recurrence of cancer by doing this serial testing, looking for minimal residual disease, and that will allow you to intervene with a more definitive treatment at an early stage rather than wait for gross metastatic disease that might be terminal, or the treatment might be palliation at that time. So that's one of the emerging technologies that showing a lot of promise, and there's a huge investment in that field with a lot of clinical trials integrating minimal residual disease in the design and conduct of the trial. The second technology that I will quickly touch upon is using the breadth of data available from next-gen sequencing to assess the choice of treatment. So rather than just simply looking at the driver mutation or looking at the fusion that you can target with a precision oncology, you could also look at the tumor mutation burden that is a byproduct of sequencing a lot of genes, or looking at the loss of tumor suppressors that can inform you about the tumor microenvironment and the likelihood to respond to checkpoint blockade, looking at finding something like STK11 or KEAP1 mutation might inform you that that tumor will likely be resistant to immune therapy alone, so you can combine immune therapy plus chemotherapy, or you can use a cocktail of multiple checkpoint blockade, etc. The third technology that I would like to highlight, even though it's still pretty much in its infancy, is using ctDNA technology or liquid biopsy, not just to guide or inform the treatment of a patient with established cancer, but actually to help add context to the surveillance for cancer in patients who do not have cancer. So we know today that there is guidelines to support the use of mammogram to detect early breast cancer, or colonoscopy for colorectal cancer, or PSA for prostate cancer, low-dose CT scan for lung cancer. All these technologies are focused in one histology, and they have their own limitations. The most likely and the most significant one is the false positive results or the low sensitivity. All these limitations of the surveillance assays could be remedied to some degree or boosted by combining the imaging technology with ctDNA technology to help you decide whether the patient is likely to have cancer or this is a false positive or negative. The other thing is that there is even newer technology than that. These are dedicated blood assays that are based on a combination of DNA methylation and point mutations that will allow you to detect up to perhaps 50 or even more cancers in individuals who are completely free of cancer. So this is a totally new surveillance platform. There is an acronym for it. It's called Multi-Cancer Early Detection, or MCED, and there's a lot of emerging companies are developing these assays. The hope is that one day the patient goes to their primary care once a year for an annual physical exam to make sure that check blood pressure or cholesterol. You can draw one of these tests and find out if the patient is or that individual having an early cancer that can be addressed at a curative stage rather than waiting until it's a stage 4.